Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Deb Smith. Ms. Smith, the floor is yours.
Thank you, Wes. Good afternoon, everyone, and thank you for joining us today to learn about and discuss the 2016 NHSN updates. My name is Deb Smith, and I'm one of the improvement consultants working for VHQC, the quality improvement organization for Maryland and Virginia. I just want to take a few minutes to review some housekeeping items before I introduce today's speakers. First, this call is being recorded and will be shared through the VHQC online community and by the stakeholders involved with planning this webinar, so watch your emails. All of your lines are on mute right now. We will have a question and answer period at the conclusion of the presentation. You'll be given instructions then on how to ask your questions. However, during the call, please use the chat box to the right of your screen to ask any questions or comments during the presentation. I'll be monitoring the chat box today, so any questions that are logged in chat that we don't get to in today's webinar will be answered and sent out to the participants after this presentation. Next slide. As we know, it takes a team to work on quality improvement, patient safety, and infection prevention. We're fortunate to have a great team of stakeholders who have worked to plan this webinar today. I want to recognize Virginia APIC for their continued support of infection prevention activities in Virginia and for sharing their knowledge, tools, and resources beyond the state borders to our Maryland providers. I'd also like to thank the Virginia Department of Health for preparing the presentation for today's webinar. Next slide. It is my pleasure to introduce our speakers for today, Andrea Alvarez and Sarah Lineberger. Andrea is the HAI Program Coordinator for the Virginia Department of Health, and Sarah is the HAI Epidemiologist for the Virginia Department of Health. Both Andrea and Sarah bring years of knowledge and experience to the table, and they're excellent resources for everything infection prevention and public health related. So ladies, the floor is yours.
Great. Thank you, Deb. This is Sarah. Today we will be discussing NHSN surveillance strategies for success. As we proceed, you'll see that we've tried to list resources on each slide. If there are sources we can't find after the webinar, feel free to reach out to us. If you haven't already, we would ask that you answer the polling question. That's just information you're curious about. We will start by reviewing NHSN updates that took effect at the beginning of this year. NHSN version 8.5 was released in early January. In 2016, there have been no reporting additions for the CMS Hospital Inpatient Quality Reporting Program, which is great news. There are also no major changes to the NHSN surveillance definition. The 2016 version of the Patient Safety Component Manual was recently posted in its entirety on the NHSN website at the link on the slide. The surveillance protocols and definitions contained within the manual should be used for surveillance and data collection beginning with events on January 1, 2016. The 2016 data collection forms have also been posted. There have been some NHSN system changes in 2016 for the patient safety component. The changes we will review are outlined here. We will go into more detail on the following slide. The first update we will review is data entry for catheter-associated urinary tract infections. At this time, the 2015 data entry defect has been fixed, and you can now enter urgency, frequency, and dysuria if in place is chosen. You will receive an alert that these symptoms should only be selected if the urinary catheter was not in place at the time of the symptoms. In addition, if you used the workaround solution that was pushed out in April 2015, you can now edit clotting with events July 1, 2015 and forward. See the December 2015 NHSN newsletter for more details. As you all know, the ICD-10, PCS, and CPT procedure codes have replaced the ICD-9 CM code. The changes took effect with the January 2015 NHSN release. If you have specific questions, see the SSI page on the NHSN website. As is current practice, the use of procedure codes within the NHSN continues to be optional. Facilities who choose to enter the NHSN Operative Procedure Code category, or instead enter one of the ICD-10, PCS, or CDC codes, and then have NHSN auto-populate the NHSN Operative Procedure Code category. For knee and hip replacement procedures, users will need to refer to the guidance to correctly input this data. Please see the supporting materials section at the link on the slide. The next change to highlight is that acute care hospitals can now set up a location for an outpatient operating room using new location codes. These locations are considered an outpatient operating room or suite that is either attached to or detached from the affiliated acute care hospital, but that shares a CMS certification number, or CCN, with the acute care hospital. For ambulatory surgery centers, the current ambulatory surgery center outpatient OR location has been revised to be specifically used by facilities enrolled as ambulatory surgery centers. For more information, see the September 2015 NHSN newsletter. The next few slides focus on reporting of MVRO and CDI Lab ID events. As a reminder, starting in January of 2015, to be compliant with CMS IQR requirements, facilities must report non-duplicate Bacteremia and CDI positive specimens from fact-wide in for all Lab ID events occurring in all inpatient locations, emergency departments, and 24-hour observation locations. Taken together, that means Lab ID event reporting includes specimens from both admitted and non-admitted patients. VDH has worked with many facilities over the last couple months who are not in compliance with Lab ID reporting from their EDs. On your screen are the basic steps that must be taken to initiate reporting from new units. We would also like to remind everyone that your facility should be keeping an internal line listing, or log, of all positive CDI tests so that you can track the duplicate CDI positive results. As you know, a duplicate CDI toxin-positive lab result from the same patient and location within 14 days should not be entered into NHSN. There is a Lab ID event calculator available on the NHSN website to help with data entry decision-making around the 14-day rule. For more information, see Chapter 12, page 17 of the Patient Safety Component Manual. Beginning in January 2016, 2 questions on the Lab ID event reporting changed from optional to conditionally required. The 2 questions are listed on the slide. Last, physical overnight location of patient immediately prior to arrival into facility. And secondly, has the patient been discharged from another facility in the past 4 weeks? And if yes, from where? The decision to require these previously optional fields was made to improve patient tracking through the continuum of care and to better align categorization of community onset healthcare facility associated CDI Lab ID events. Data gained from these fields can be used to identify potential reservoirs where continued high rates of CDI may exist, and to provide better guidance to target CDI prevention in non-acute hospital environments. Additionally, the information can help address regional variations in CDI rates. Lab ID event surveillance was originally intended to reduce manual data collection burden by focusing on data that could be entered by electronic capture. CDC had originally planned to make these two questions required. However, the instructions for 2016 acknowledged that the data for these two additional questions may not be retrievable or may be excessively burdensome if left in some facilities. Therefore, facilities may use the unknown option if answering these questions is too burdensome. Keep in mind that a helpful IT team pointed out to us that the unknown option is not automatically populated for new Lab ID events that are entered into the system. Thus, even if we make use of the unknown option, we will still have to go into each event and mark unknown for these two questions. There are a couple other changes to highlight for Lab ID reporting. The following question for Lab ID events has been changed from in the past 3 months to in the past 4 weeks. Has patients been discharged from your facility in the past 4 weeks? This change is also meant to offer better alignment with community onset healthcare facility associated categorization. There are also new data entry fields for CRE Lab ID events. When a CRE Klebsiella, CRE E. coli, or CRE Intervector is reported in a Lab ID event, additional laboratory test questions about the testing and presence of carbapenemase will be required. Those questions are listed on the slide. Okay, this list isn't exhaustive, but it highlights some of the analysis updates for 2016. There is a new output option for reporting downgraded CDI test types. This option shows that those quarters and/or years when a CDI test method has been changed to a less sensitive test type compared to the previous time period. The analysis data set uses CDI test type data as reported on existing annual surveys and NBRO CDI denominator form. Second, the annual update to the device-associated aggregate tables is complete. The aggregate rate used in the application for CLABSI and CLADI rate comparisons has been updated to use 2014 national pooled means. The risk strata that are now in use will not be changing, i.e. the same strata implemented in January 2015 still apply. The device-associated rates are pending publication. Next, several package variables have been added to select event-level line lists, tables, and charts. And finally, on the Modify Output Options screen for the Summary Data line list, the drop-down for event type has been updated to include all possible values for event type. For details about these updates and more, see the December 2015 email regarding patient safety manual revision. Okay, now we're going to transition to talking about CDC location or unit mapping and about what data gets reported to CMS. Location mapping or mapping each of your units in NHSN is a really important step, and we'll discuss why it is so important. All of the unit mapping guidance we will discuss has been in place since at least January 2015, so this information shouldn't be new, but is important to review. As most of you know, VDH has been conducting quality assurance on MAP units in all the acute care hospitals across Virginia. As we've gone through this process, we've come across some of the same questions over and over, and we have clarified guidance with the NHSN team at CDC along the way. First, why is it important to map units correctly? The way your units are mapped forms the basis for all the reporting you do in NHSN. The way your facility's units are mapped determines how your facility's data are risk adjusted, which impacts SIR calculations. Mapping a unit incorrectly can lead to either over- or underrepresentation of your unit or facility's performance. This is because unit type is used as a proxy to represent the baseline risk of the patients in the unit. For example, if a unit has 90% neurology patients, but is marked as a general medical ward, the rate of clotting observed will be compared to a pooled mean of 1.9 rather than 3.1, leading to a higher SRR than what it should be. In other words, because neurology patients inherently have a higher risk for clotting, they will naturally have a higher number of clotting than general medical patients, and should be compared to a baseline of neurology patients rather than a baseline of general medical patients. Okay, the second new point to keep in mind is that your facility's MAP NHSN locations are used for CMS reporting. The data that are sent to CMS are the data reported for the units that fall under the CMS Hospital Inpatient Quality Reporting Program, or IQR program. That includes all critical care units, including Class C reporting from NICUs, medical, surgical, and med-surg wards, data for colon and abdominal hysterectomy procedures, and lab ID events for MRSA bacteremia and CDI from facility-wide inpatient units, emergency departments, and 24-hour observation units. Take a second and think about the fact that means that device-associated data you enter for other wards that aren't med-surg wards are not being sent to CMS. So that includes words such as mixed acuity, step-down, labor and delivery, neurology, telemetry, behavioral health, and pulmonary, just to name a few. Again, this figure depicts the data that are sent to CMS by unit location and time frame as part of the CMS IQR program. As of September 25th, 2015, VDS Regulations align with the CMS IQR program, which means VDH is now getting the same data that are sent to CMS, with one small exception which I'll go over momentarily. Note that at the link on this slide, you will find requirements for the other CMS reporting programs. There are changes in other reporting programs for 2016 that may affect your acute care hospital, such as VAE reporting from LTAC, and also inpatient psychiatric facilities and dialysis facilities that must begin reporting healthcare worker influenza vaccination summary data for the 2015-2016 influenza season. One other thing I want to mention is that while CMS and VDH can only see the data from the units and time periods listed on the slide, CDC, which created and manages NHSN, can see any and all data being put into NHSN. I wanted to point out that Chapter 15 of the Patient Safety Component Manual contains all the definitions and directions for mapping locations. If you haven't already, I would strongly suggest that everyone on this call read pages 2 through 8, which give an overview of how to make location changes, including some helpful examples. Note that the text on page 4 states that mixed wards, whether they are mixed acuity, mixed age, or both, are not included in device-associated reporting to CMS, or VDH. Okay, we're now going to walk through some questions, all of which have come from IPs across Virginia. The first question is, when I initially mapped my nursing units in NHSN, we were trained to select the option that most specifically describes the nursing unit. Now with CMS reporting, it looks like I may need to modify some of my nursing units to a more generic or general location description in order for the data to be sent to CMS. Okay, this is a really important question, and we've had similar conversations with many hospitals over the last couple months. So we consulted with CDC, and the answer is that NHSN stands by their original recommendation to map units as accurately and specifically as possible, according to the location guidelines in Chapter 15. NHSN does not recommend mapping wards more generally, just to be included in CMS reporting for device-associated events. This is a very important issue for risk adjustment and for obtaining the most accurate SIRs, which we discussed extensively on slide 19. From an NHSN perspective, misreporting your unit's data with an incorrect mapping can have an impact on the risk assessment and benchmarking done by NHSN. If more specialized units are being mapped as general units, the NHSN aggregate data will have lots of data for general unit types, but little for special unit types. This prevents NHSN from getting precise pooled mean estimates of risk and reduces the ability to benchmark HCI rates for those unit types and include them in the NHSN risk adjustment metric. The data for general unit types would also be much less informative as a benchmark comparison, as it would not take into account the differences in patient risk populations. In essence, facilities that map units incorrectly would end up doing themselves a disservice in the long run. All that being said, if the patient population in your unit has changed, and for example, your mixed acuity ward now meets the 80% rule to be an adult medical ward, then by all means, let's talk about updating your unit mapping so that your data are counted most accurately. All we're saying is don't change your location mapping just to make sure that device-associated data are sent to CMS. Okay, the next question is, I am tracking data for a mixed unit and a step-down unit for my hospital. Since that data isn't being sent to CMS, should I set the units as inactive in NHSN? And the answer is no, you do not need to make the units inactive. You are able and encouraged to map and enter data for your hospital's other units in NHSN for internal tracking purposes. Also, keep in mind that even though device-associated events aren't being sent to CMS for other types of wards, data from all inpatient beds is being sent to CMS for lab ID reporting as defined by Chapter 12, with a few exceptions. CDC ensures that only data required by the hospital ICR program will be sent to CMS. Now to talk about reporting to VDH. As I mentioned previously, the VDH HCI reporting requirement recently changed to align with the CMS ICR program. The exception being that VDH has copy data from ICUs going back to July 2008 based on a prior state reporting mandate. For more information about public reporting of HCIs in Virginia, please visit the link on the slide. As mentioned, VDH has been conducting quality assurance on mapped units in all these sister hospitals across Virginia. The QA process we've been conducting was to whether your facility, 1, conferred rights for all the same units, whether 2, in your NHSN monthly reporting plans, and that 3 fall under the CMS and VDH reporting requirements. I want to walk through these 3 pieces to the NHSN reporting puzzle. Okay, first the question, how do I know if my facility conferred rights for the same units that are in my monthly reporting plan? Okay, to determine which units were included when you conferred rights to a group, follow the steps on this slide, although I have to apologize because this is the VDH view and not the hospital view. So when you get down to the arrow that points to group level data, instead click on facility level data, which is right above that, and then CDC defined output, and then the line list called line listing conferred rights. Click run. NHSN will generate a line list that shows you which units you conferred rights for by group. So the group will be specified in the first column called parent and org ID. For example, the VDH group ID is 12813. So if you have conferred rights to VDH, all the units for which you conferred rights will be listed out. So those steps again were to click on facility level data, then CDC defined output, and then choose the line list called line listing conferred rights. Secondly, To find or edit your monthly reporting plan, follow the steps on the slide. You can choose the month and year for which you want to view and click Find. The third piece of the NHSN reporting puzzle was to define which units fall under the CMS and VDS reporting requirements. Since we've already talked about where to find the CMS reporting requirements, we now know every puzzle piece VDH was considering during our recent QA process. Okay, now for more questions from IPs across Virginia. Question: I thought my monthly reporting plans were fine, and when I went back to look at each month, I realized my October 2015 plan didn't include anything for the procedure associated module. What happened? And the answer is that if you copy your monthly reporting plan from one month to the next, please be sure to copy each module or section of the plan, including device associated, procedure associated, and NDRO. If you don't click on each module, only the top module, the device associated one, may copy over to the next month. Okay, we've had a lot of questions about inactive units. Once created, units cannot be deleted in NHSN. They can only be set as inactive. First, I want to remind you that rights should be conferred to VDH for all active and inactive units, so that we have access to historical data across the state. Question: will I lose the data if I make the unit inactive? Answer: no. Data which has been reported from inactive locations can continue to be analyzed within NHSN. Keep in mind that inactivating a location will simply remove the location as an option in the location dropdown during data entry. All data reported for inactive locations will still be accessible and available in analysis output options. In addition, any inactive locations can be reactivated as needed. The reason to set a unit as inactive is to prevent someone from erroneously associating an event with that unit if it really is inactive. This is especially important when multiple staff members are entering event data for your hospital and or if the staff entering data change over time. On this slide is a list of scenarios and references if you have further questions about managing inactive units. Please read through these instructions and reach out to us with questions before setting units as inactive. Now to discuss emergency department. Because Route ID event reporting from ED was a new reporting requirement as of January 2015, I wanted to quickly review the NHSN definition for an emergency department. An ED is an area that provides emergency medical services. It is differentiated from a pediatric ED, that is, an area that provides emergency medical services to patients 18 years old and younger. Note that any freestanding EDs affiliated with a hospital should also be mapped as an ED unit. Now for another question. Since the new NDRO reporting requirements for EDs went into effect in January 2015, I have been reporting MRSA and CDI data for backside out at the overall facility-wide level for outpatient areas. Does that cover the required ED reporting? And the answer is no. Backside out reporting does not meet the requirements for NDRO reporting from ED. You must map your ED as a specific unit in order for the data to be counted correctly. The same thing goes for 24-hour observation units. We must map the odds unit separately and report data for that unit. Your facility is welcome to backside out reporting, but you must also report for ED and 24-hour observation units as applicable. There is currently not a reporting requirement for backside out. Because Route ID event reporting from 24-hour observation areas was also a new reporting requirement as of 2015, as of January 2015, I wanted to also review this definition. A 24-hour observation area is an area where patients are monitored for suspected or life-threatening conditions for 24 hours or less. More than 50% of patients in this location must be outpatients who are not expected to be admitted to an inpatient location. Note the use of a 50% rule, which is different than the standard 80% rule from most other NHSN locations. Please review your hospital's observation areas to determine whether or not your facility has an observation unit that meets this definition. Okay, as we all know, units open and close. Patient populations within existing units may also change. We have recently reviewed with most of the Virginia hospitals which units are reporting data and for which units you have conferred rights to VDH. But it is important for the IPs to assess the patient population for each of your units to determine if the units are mapped correctly. It is best practice to review each of your units on an annual basis, and the best time to do so is around the start of a new year, since the cleanest time to make a change to location type would be at the start of a new calendar year. For example, if you change a unit location type now, you should do so for all data effective January 1, 2016. NHSN recommends verifying each location for CDC location designation, bed size, active and active status, and non-duplication. Also keep in mind that if you create a new unit, then you must go back and reconfer rights for the new unit. You would have to reconfer rights for each group to which you conferred rights, such as VDH, VHQC, etc. To view your MAC location, follow the directions on this slide. A couple other data quality reminders. The first is making sure your facility is capturing the correct date of admission. In the interest of time, I'm going to refer you to the September 2015 NHSN newsletter. The second reminder on this slide has to do with denominator data for CDI lab and event. We have recently done some checks with CDI denominator data and have found some common mistakes. Please see Chapter 12, page 18 for more information. Okay, now let's discuss the annual facility survey. The 2015 Patient Safety Annual Facility Survey is now available and should have minimal changes from last year's survey. This mandatory survey is completed by all facilities enrolled in NHSN to provide updated information on hospital characteristics and practices. The survey should be filled out for your hospital based on the 2015 calendar year, specifically what was happening in your hospital for the majority of 2015. Please pay close attention to variables used for risk adjustment, including bed size and medical school affiliation. Earlier in the fall, VDH conducted QA on those variables, and we will go through some questions and answers pertaining to them. Surveys must be completed and submitted in NHSN by March 1st, 2016. Facilities that do not meet this deadline will be unable to complete monthly reporting plans. Okay, first we will cover the annual survey variables that pertain to bed size. As you all know, you are asked two questions about bed size on the annual survey. The first is question A on your slide. The number of beds set up and staffed in the ICU. The second is question B. The number of beds set up and staffed in all other inpatient locations. On the bottom half of this slide is an excerpt from the directions for the annual survey, which further explains those two variables. An IP asks, the definition for all other inpatient locations is confusing. Does all other inpatient locations mean all non-ICU inpatient beds? And the answer is yes. All other inpatient locations is all inpatient beds not already included in the ICU bed count. NHSN auto-calculates the total number of beds in your hospital by adding the two variables you submit, i.e. the answers to questions A and B. A couple other reminders about the bed size variables. The number of staffed beds in your hospital is not the same number as licensed beds, and is also not the same number as your census. Also keep in mind that your answers should reflect the number of beds in your hospital for the majority of calendar year 2015. Okay, next we will discuss the annual survey variables that pertain to medical school affiliation. You are asked if your hospital is a teaching hospital, and if so, what type. So, and I'd be asked the following question. My hospital has affiliations with numerous medical schools. The agreements are individual and come with each student who does their teaching, which that means the NHSN criteria for undergraduate teaching programs. First, let's take a look at the directions for the medical school variables, which are printed on this slide. They state that a facility with an undergraduate teaching program is a facility with a program for medical students only. However, there isn't a lot of detail provided in the directions about how NHSN defines programs. So we talk to CDC. And the answer is that NHSN does not put any bounds on the definitions or requirements for the extent of a program needed to meet the teaching status classification used by NHSN. In this example, since the facility provides medical education or teaching experience for undergraduates, i.e. medical students, the hospital would qualify as having an undergraduate teaching status. So the idea is that CDC is trying to assign risk to the hospital so that your facility can be grouped with other hospitals that have similar types of students and thus similar risks. The question isn't well defined, but if your hospital has any students that meet the definitions on the previous slide, then that should be indicated on your annual survey. Alright, this is the last question about the annual survey we will review. Question. My hospital began having residents on site for the first time in August of 2015. Should the 2015 survey reflect a graduate affiliation, or should the affiliation not be indicated until the 2016 survey? And the answer is that you should select the medical school affiliation that was in place for the majority of the calendar year. If you started having residents in August, then you should not adjust your teaching status until the following year's annual survey, since the majority, or at least 6 months, of data were reported under the old affiliation. In this case, you would not indicate a graduate affiliation until you fill out the 2016 survey, which will be next year at the beginning of 2017. Note that risk adjustment of data is always based on the most recent survey, so NHSN tells users to focus on ensuring that the current survey is accurate. The one exception to this general rule is CDI test type, which is taken from the CDI denominator form and is matched up with that quarter's data. In terms of editing, at any given time, your facility can only edit the most recent year's survey. Thus, we would encourage you to make sure the new survey you are filling out for calendar year 2015 is as accurate as possible.
Thanks, Sarah. This is Andrea now. For infection preventionists, you've mapped your location, you've updated your facility survey, you're applying the surveillance definitions accurately and consistently. Now I'd like to share more information about data analysis and using data for action. This slide should be reviewed for almost everyone, but just to recap, when we talk about data analysis, we're often referring to the standardized infection ratio, or SIR. This measure compares the number of HAIs reported to the number of infections that were predicted based on national baseline data. So you divide observed over predicted. If your SIR is 1, that means you had the same number of infections as predicted. Greater than 1, you observed more than what was predicted. And less than 1, you had fewer than predicted, given that national baseline data. Now, the time period of the different types of SIRs varies for each HAI type and or facility type. And because 2015 is the last year that these old, or what the current baselines are going to be used, I think it's important to recap what it's like in 2015 data, using 2015 data. So for central line-associated bloodstream infections, the acute care hospital baseline is from 2006 to 2008, and long-term acute care is looking at 2013 data. For CAUTI acute care, 2009, and for long-term acute care and inpatient rehab, 2013. SSI baselines come from 2006
to 2008, and MRSA and CDI lab ID baselines are from 2010 to 2011. One of the very last slides of the presentation, slide 69, has specific resources for you, but I'm going to hit the highlights of some of the baseline information in the following slide. You may get asked by your infection control committee or from physicians, where does this predicted number of infections come from? And with the current risk adjustment, the collapsing body, it's adjusted for the type of patient care location, and this is based on national pooled mean rate. Some units also include an adjustment for hospital affiliation with medical school and for bed size of the patient care location. SIRs for the complex admission or readmission SIR differs by type of procedure, but it uses a logistic regression model that is specific to that procedure. And some of the variables included in these models include things like duration of surgery, the surgical wound class, use of endoscope, patient age, or patient assessment at time of anesthesia. It's a bad typo, or ASA score. For the lab ID, it uses a model called a negative binomial regression model. And for both MRSA and CDI, this adjusts for facility bed size, hospital affiliation with the medical school, and number of community on-site events. Additionally, the CDI SIR adjusts for the type of test that your lab uses to identify C. diff. The rebaselining process has been in the works for some time and is much needed due to several changes that have occurred in recent years. So since those original baselines, there have been numerous changes to NHSN definitions and surveillance protocols, a huge increase in number and types of facilities reporting to NHSN, changes to facility demographics, increases in reporting, types of HAIs, different locations, more procedures, more group users such as VDH and VHQC, and increase in your prevention activities. The CDC is planning to use 2015 data to make baselines for the events and healthcare facilities on your screen. In addition, ventilator-associated events, mucosal barrier injury, lab-confirmed bloodstream infections, antimicrobial use and resistance modules are also anticipated to have new baselines using 2015 data. There will be much more information coming about the rebaselining process as it becomes available. Please know that the risk adjustment methods and risk models themselves will likely vary from the previous baselines that I have described in the prior slides. CDC is moving toward using a risk model approach for adjusting the Class C and CAUTI data. And this will mean that location stratified rates will not be available at the national level. This approach will allow for assessment of some of the other factors listed on your screen. So this slide came directly from a CDC talk that I attended back in November, so hopefully this timeline is still in effect. Through spring of this year, CDC plans to continue their preliminary analysis and risk adjustment work, and in June to run some final analysis to ultimately complete it by mid-July. In mid-August, the 2016 quarter one data will be submitted to CMS using the new 2015 baseline. And with the December 16, January 17 NHSN application, the new SIRs and risk adjustment models will be incorporated. For 2015 data, CDC will continue to share SIRs to CMS using the old baseline, our current baseline. And then they will be providing replacement SIRs using the new baseline once they are available in the second half of this year. This transition period may be a bit confusing, but we anticipate that CDC will provide us with guidance on how to navigate these challenges together. The new baseline and risk adjustment methods will be implemented in the December 16, January 17 release, as I mentioned, and there will be new output options that will allow users to calculate SIRs on the new baseline for data from 2015 and forward. You will also have the opportunity to calculate legacy or old SIRs on the old baseline on data from 2016 and backward. So that will allow you to make some comparisons between the old and new baseline for 2015 and 2016 data so you can see how they differ. This slide has some other changes anticipated for the 2017 release, just to give you a heads up about some of this. There's some new device-associated output options. The MBI, LCBI will have its own rate table, and a few other options. But in the interest of time, we'll skip ahead. In some of our last minutes together, let's transition to talking about the Targeting Assessment for Prevention, or TAP strategy. We hope that many of you have heard of this strategy and have started using this approach to drive change in your facility. The first step, target step, is to identify facilities or units with a high burden of HAIs and to assess the infection prevention gaps in those units, and finally to prevent HAIs by implementing specific interventions. TAP reports in NHSN can help a state, group, such as VDH, or a facility initiate the target step. TAP reports are available for CAUTI for all three unit types, or all three facility types on the screen, and for CAUTI and CDI in specific healthcare settings. The TAP reports use a metric called the Cumulative Attributable Difference, or CAD, to help identify the units or facilities that had more infections than predicted. The number of predicted infections are multiplied by an SIR goal, which can be the goal of a state, the nation, such as the HHS National Action Plan target, or something specific to your facility or healthcare system. That number is subtracted from the number of observed infections to get the CAD. The CAD can also be interpreted as the number of infections needed to be prevented to reach the SIR goal. A larger CAD means there are more infections to prevent, and a smaller means that there are fewer. To run the TAP report in NHSN, navigate to your analysis screen and then output options. There's a folder called TAP Report and specific reports for different healthcare settings. Click the Modified button to set your time period and SIR goals interest, and NHSN will provide the data for you. So a piece of homework for all of you for next webinar. Please take the time to run a CAUTI TAP report with the following specifications. Modify the date variable to be summary Y2, and set the time period as 2015 quarter 1 to 2015 quarter 4. And please use the HHS goal of 0.75 as the CAD multiplier. Save and review your output for next webinar. We'll talk more about how to interpret that. And between now and next webinar, please complete your first facility survey if you have not done so already, due by March 1st, as Sarah mentioned, and finish entering your 2015 data, including reviewing your units for accuracy. Next week on the 15th is the CMS deadline for reporting for all three settings: acute care, long-term acute care, and inpatient rehab hospitals. So please make that note. And we also encourage you to review and share the NHSN communique from October 2015 that's listed on your slide. This document is a reminder from CDC and CMS that adherence to the NHSN infection definitions and criteria is needed to ensure accuracy, completeness, and comparability of infection information. So if you're getting pushback from physicians or others in your hospital challenging you about surveillance definitions and why we need to follow them, this is a reminder that you can share with them that emphasizes the importance of doing that and also notes possible consequences for hospitals that intentionally report incorrect data or deliberately fail to report required data. This webinar is the first in a series of 3, the second being on March 11th to further review the top reports and strategy, and the third on April 8th. And on April 8th, we'll be recapping some of the lessons learned and interesting tidbits from the CDC NHSN training, which is February 29th to March 1st, a full endless week of data goodness. The live web streaming is available for those of you who are not able to attend in person, and no registration for the web streaming is required. We have some contact information, we have some references, and we have time for questions. If you don't get a chance to ask your question, please use the chat function. And there are lots of questions in the chat box, so we'll get to as many as we can in our time together, and we'll follow up with you individually as well as a group following that. So I guess let's open the line.
So do we also have the results of the polling questions?
Oh,
they are. Okay, we just wanted to write that down. But Deb, if you want to go ahead and start with questions, that'd be great.
Thank you.
Open for your questions. If you have a question, please press 7 on your telephone keypad.
Thank you, Wes. So as Wes said, anybody that has a question and wants to ask it right now, just press 7 on your telephone keypad. Wes, do we have any questions right now?
Yes, there's a question from Lisa. Lisa, the floor is yours.
Hi, thank you for hosting this webinar. I just had a quick question. So, usually I run the CMS Lab ID report, and it just generates a SIR and a number of the hospital onset cases. And I wasn't sure if there's a way to identify which patients fell into that category of hospital onset, because I know that it's the definitions are a little bit different, and I see that when I run the line list of the Lab ID events, I get a different number than what's actually generated for CMS. I'd just like to know which patients are actually being categorized into hospital onset for CMS so that I could just dig into them a little bit deeper. I'm not sure if you have any suggestions.
Thanks for your question, Lisa. I think that's something we may need to look into a little bit more, because I would have thought that the overall line list of CDI events, it does have that variable that indicates hospital onset. So if you're saying that that doesn't match up with the SIR numbers, then that is concerning. And
yeah. So example, when I run a line list for C. diff events for a quarter, I had 12 that were classified as hospital onset, although I didn't quite agree with the classification of hospital onset. And then when I ran the CMS report, it just gave me a total of 10. So I thought, okay, well maybe they extracted those to erroneous ones that I thought did not meet the definition. But there's no way for me to look into those 10 that are being, classified as hospital onset for CMS.
Do you think you can email us? Because this is a great question. I think it's going to take more time to work through.
Sure.
But we would be happy to figure it out with you and then email the group as a whole.
Sure. Who should I email?
You can either email Sarah or Andrea or both.
Sarah, can you go back to the slide that has the... Okay, thank you.
Yeah, slide 68. Any other questions?
And I'm sorry, this is Felisa. I was unable to actually see the webinar. I had to view it from someone else's computer, but is there an email for Sarah or Andrea?
Oh, yeah. Andrea's might be easier. It's Andrea.Alvarez, ALVAREZ, at V as in Victor, D as in dog, H, so VDH, dot Virginia spelled out, so VIRGINIA.love.
Okay, thank you so much. I appreciate it.
Wes, do we have any other questions in queue?
At this time, there are no further questions.
Okay. We do have a couple questions that came through in chat. So, is there a way to pull a line list of CMS Lab ID events in NHSN? Was this what was just asked? I noticed that when
similar question. There is a line list option within the analysis functions for the MGRO module that do allow you to pull a line list, and there's a variable that indicates whether it's community onset, hospitalist onset, or the other category.
Okay. And just let me look through here again. So another person asked, I see the reporting specification for surgical. We just changed our unit type to orthopedic. Does this mean that the new unit designation will not be counted? It is an orthopedic surgical unit. Should it be called surgical instead?
Yeah, so this goes back to the unit mapping. Thanks for the question. So if it's an orthopedic unit, the device associated data, so the Class C and Class D data for that unit wouldn't go to CMS. But any lab ID events would still be counted for that unit as part of the FACWIDE and lab ID reporting. It's essentially it's up to the hospital to decide what type of unit it is, because we have no way of knowing what the patient population is. So it's definitely something we can talk more offline about, whether it should be an orthopedic unit or whether it should be a surgical unit. But again, the way you classify your ward would be based on the patient population and not based on which data it's going to be reporting to CMS. It is a good question, but it just goes back to the patients in your unit. So, if you want to talk about that more offline, that'd be great. But I appreciate the question. The unit mapping stuff is really confusing, and so we've ended up having essentially individual conversations with most hospitals about their unit mapping.
Okay, and I'm going to ask one more question before we sign off today. Would our urgent care center that is freestanding be considered an emergency department?
No, that's a great question. Urgent care centers are not considered emergency departments.
All right, and we do have a couple other questions that we will get to and send them out, the answers, to everyone who participated today. I want to thank you all for attending and participating in today's webinar. Thank you, Andrea and Sarah. It was a great presentation, lots of information. I hope everybody saves these slides as a reference for themselves. Remember to complete the evaluation if you haven't done so already. And don't forget to mark your calendars for the next two webinars in this series. So the next one is March 11th, and the one after that is April 8th. They are both from 12 to 1. If you get time before the next one, please use the instructions in these handouts to run your TAP report for CAUTI so that you can have that as reference during that next webinar.
Hey, Deb, there are a couple questions about whether or not the slides will be available. And they are available, and we tried to send them out before this, but if you need a copy of the slides, feel free to email any of us, and maybe Deb can send them back out as well.
Yes, they should have gone out. And just look at your the registration or any reminders that you got today, because the slides, there's a link to the slides at the bottom of that email, that reminder. But yes, absolutely, we can send them out to anyone. So any other last remarks? We are 1 minute over. All right, well, thank you all and have a wonderful afternoon.